This is wrong. Ulceration of the cellular epithelium and thinning of the epithelium. Okay, will lead to the exposure of the blood vessels. So when you probe, what will happen? The vessel wall ruptures and it bleeds through the sulcus. So this is the reason for bleeding on probing. Okay, if there is a spontaneous bleeding, what is the reason? If there is a spontaneous bleeding, what is the reason? Yes? Anybody? Hemorrhagic disorders like vitamin K deficiency, vitamin C deficiency, hemophilia, A and B, Christmas disease. So all these are the commonly asked questions in your Viva. Almost every candidate will be asked such kind of question. So you are supposed to write this clinical features of periodontal pocket. They're going on to the pathogenesis of periodontal pocket. So this pocket starts as an inflammation in the connective tissue wall of the gingival sulcus. Again I repeat, it starts as an inflammation in the connective tissue wall of the gingival sulcus. Okay, this pathogenesis will also be asked in the Viva. Okay, so what happens? This inflammatory exudate will destroy the gingival fibers. Okay, the inflammatory exudate will destroy the gingival fibers, and the fibroblast that is present in the gingiva will extend the pseudopodia-like process, just like an amoeba, to the ligament-cemented interface. The fibroblast will extend the pseudopodia-like process to the ligament-cemented interface that will engulf the gingival fibers, destroy gingival fibers. Okay, so this is initiated by two mechanisms. One is collagenases and MMPs. See, previously they thought that the bacteria is causing periodontal disease, but now the concept has changed. We are destroying our own body. What is the reason for self-destruction? What is the reason these days? Getting up in the morning, coming to the dental college by 8:30, 7:45, 9 o'clock is a stress, right? Studying is even more stress. Sitting in this room, listening to my lecture is another big stress. Yes or no? Yes. No. Okay. Very good. Thank you. So, when you are stressed, what happens? Your cortisol level goes up and your neutrophils come down. So, we are destroying our own body. So, the current concept is more than the bacteria, more than your enemy. Okay, it is your nearby circle that is going to affect you. Okay, so the people who are nearby you are going to affect you. So, it is your own body destroys your own cells. Okay, so that is what is the collagenase and MMP. So this collagenase and MMP is secreted by the person's own body that is going to destroy the extracellular matrix. So what happens? The junction epithelium proliferates and it migrates apically, and the coronal part of the junction epithelium detaches from the root surface. So what happens in any area of infection? What is the first line of defense? Louder? Neutrophils. So neutrophils come to the particular site, and when the concentration of neutrophils reaches more than 60%, tissue loses cohesiveness and detaches from the root surface. So that is how a pocket is formed, and the sulcus water shifts apically, resulting in a periodontal pocket formation. Is it clear? Or you have any doubts, please stop me then and there. Yes, no, all of you are sleeping. That's what I asked you to stress to attend my lecture. No ma'am, you're forced to say no ma'am, there's no other word to say. Okay, so moving on to the next part, what you have to write is the microtopography of the periodontal pocket. So when you see microtopography, I think I will just brush through. So you have the area of relative quiescence, where it is very silent. Then you have the area of bacterial accumulation, where you have the accumulation of microorganisms. You have both gram-positive and gram-negative organisms. And then you have area of emergence of leukocytes. Then you have area of leukocyte-bacteria interaction. And then you have areas of intense epithelial desquamation, areas of ulceration and areas of hemorrhage. This is what you're going to see under the microscope. So you're supposed to write about the microtopography of the periodontal pocket when it is asked for 10 marks. Next what you should write is your periodontal pocket contents. So what does it contain? It contains microorganisms, gingival fluid, food remnants, salivary mucin and eosinophilic reticle cells and leukocytes. And what does pus contain? It is the dead and degenerated polymorphonuclear neutrophils which is going to liquefy the tissue there. In addition to that, you have a scant amount of fibrin. Okay, next what you are supposed to write is the surface morphology. Loose. Okay, is the surface morphology of the root surface. So in 1946, Barr studied the different zones that are found at the bottom of the pocket. So the first zone is the cementum colored calculus. There is something. Projection. Okay, to continue. So after this you have a zone of attached plaque that measures around 100 to 500 microns. And then you have a zone of unattached plaque. And then followed by a zone of junction epithelium that is around 100 to 500 micrometers. But in case of periodontal pocket formation, it reduces from 500 microns to 100 microns. And then you have a zone of semi-destroyed connective tissue fibers. So next you are supposed to write about the area of decalcification and remineralization. So you can see, what can you see in the first picture? What do you see in the first picture? Root caries. So what is the reason for root caries? There is an area of demineralization. Yes? So that is the reason. So how does it appear? The area? How does it appear? There is a brownish or an yellowish brown colored patch, right? So it is the area of demineralization. And what microorganisms are predominantly seen in that? Actinomyces viscosus is commonly seen in root caries. So you are supposed to write. So what happens in the areas of hypermineralization? So in the areas of hypermineralization, you have more amount of calcium, phosphorus, magnesium, fluoride being deposited. So this is, you are supposed to write all these things for your 10 marks. So what are pulpal changes? So all of you know about periodarshan lesions. So what are pulpal changes you come across? So what? How do you identify it is periodontal problem or a pulpal problem? What is the test used to identify whether that's a periodontal problem or a pulpal problem? If there is a pain on percussion, vertical percussion, what problem is it? Pulpal. If there is a pain on lateral percussion, what problem is it? What is the reason for periodontal problem? Why it is painful to lateral percussion? How does the infection spread from the periodontal ligament? Through the apical foramen as through the lateral canals. Okay, so there is hyperemia of the pulp and there is a hyper-responsive pulp that is seen there in periodontal pocket. So this is what I already told you. Many of the clinics don't have this flow. Okay, so as a general dentist, we have to have like an exploder, a Williams periodontal probe. So what are the markings on the Williams periodontal probe? One, then one. One of you please get up an answer. I'm not able to look at you. What are the markings? Yes? Ma'am is asking whether you are talking among yourself or you are responding to me. Yes, please answer. You're from your name and you're from which college? You're from? Periodarshan. Very good. Yeah, please answer. Very good, very good. 4 and 6 are missing. Okay. So do you have Williams periodontal probe? Yes? Okay, so all of you should have a Williams periodontal probe. Okay, another second question is, so if you have a probing pocket depth of 4 mm, what treatment you are supposed to do? Scaling. Anything else? Root planing. Very good. If it is 5 to 6 mm, yes? Flap surgery. Very good. Okay. So this is the decision tree for non-surgical management of periodontal disease. That is, I told you, when there is a probing pocket depth of 4 mm, what is your decision tree? How do you go about the diagnosis? So, if there's a patient has got a chronic periodontitis, there's an active disease, you do a scaling and root planing as you said for a probing pocket depth of 4 mm and you re-evaluate the patient. So, after you re-evaluate the patient, you have 3 scenarios here. The first scenario is 1 to 2 sites per quadrant, okay? 1 to 2 sites per quadrant or 4 to 5 sites in the mouth with 5 to 6 mm of probing pocket depth. Listen to me carefully. 1 to 2 sites or 4 to 5 sites per quadrant with 5 to 6 mm of probing pocket depth. The second scenario is more than 1 to 2 sites per quadrant or 4 to 5 sites with 5 to 6 mm of probing pocket depth and 7 mm or greater than that. So, in the first scenario, we do something called as local drug delivery. What is local drug delivery? Anybody? What is local drug delivery? Anybody? What is an antibiotic? What is an antibiotic? Yes? What is an antibiotic? Huh? Anyone? This is the locally delivered antiseptic or an antibiotic. It's called as local drug delivery. In addition to scaling and root planing, you have some agents which is delivered in the periodontal pocket. Okay, so that is called as local drug delivery. And after that, if you see any improvement, you continue with the periodontal maintenance. If there is no improvement, you go in for a flap surgery. Similarly, if the probing pocket depth is more than 7 mm, you go in for a periodontal flap surgery. This is the decision tree for non-surgical periodontal therapy. As I already told you, this local drug delivery can be applied professionally as well as personally. Okay, at home. So personally is non-sustain. What do you mean by sustain? All of you are using a mouthwash, right? So what is the duration of action of a mouthwash? It contains chlorhexidine. What is the duration of action of a mouthwash? 12 hours. So what is that? Substantiality. What is the meaning of substantiality? Yes? Yes? It is produced in small doses over a period of time, right? So it is non-sustained, but what you are going to apply personally is non-sustained. You have some irrigation devices which is very commonly used abroad. It is called as water pick, for example. Next is professionally applied devices can be sustained and non-sustained. The sustained devices are your tetracycline fiber. This is called as Actisite, and in India it is marketed as Periodontal AV Plus, which in most of the colleges it is available. I think you have seen in the department also. These are tetracycline fibers which will degrade within the pocket and reduce the probing pocket and arresting the disease. The second one is your doxycycline, it is antidox, and third one is your minocycline microspheres, that is called as arrestin. So these are available in the market. Non-sustained devices are supra and subgingival irrigators like povidone, iodine and chlorhexidine. So these are the, you can take the presentation from MAM if they give it, but these are the list of approved local drug delivery agents and their mechanism of action. I'm not going into details, this is up to the postgraduate level. Now moving on to the surgical management. So we finished with non-surgical management. So when there's a probing pocket depth of 4 to 5 mm, we do a non-surgical management. Either we do a scaling and root planing or we do a scaling and root planing with local drug delivery. If there's a probing pocket depth of more than 5 to 6 millimeters, we do a surgical periodontal. What is 5 mm standard for referral? What is 5 mm standard for referral? When the probing pocket depth is above 5 mm, as a general dentist, you are supposed to refer the patient to a periodontist. It is called as 5 mm standard for referral. It is given in a cancer textbook only. Okay, so when a probing pocket, that is why the 4 and 6 is missing in your Williams periodontal probe, because 5 is a demarcation to differentiate between non-surgical and surgical treatment. Okay, so moving on to the surgical therapy. Why do we have to do a surgical therapy? Why scaling is not enough? Why do I have to open a flap? It's no more called as flap surgery. It's called as open flap debridement, right? It is no more called as flap surgery. If you don't know, please know. It is called as open flap debridement. And why do we have to do open flap debridement? Accessibility, visibility. Okay, so we open the flap and do the same procedure, scaling and root planing, and we plane the root surface. We remove the infected granulation tissue. If there is any defect, we place the bone graft. If there is only no defect, we do a resective surgery and close the area. Okay, with the different types of sutures. So the pocket therapy is divided into pocket elimination and pocket reduction. So under pocket elimination, you have 2 procedures. Here I have highlighted only on gingivectomy. I won't be going into the details because I think the Periodarshan will be talking on surgical aspects of odontology. I will just tell you what has to be written in concise form. Okay, so you have to write a little bit about gingivectomy. What is gingivectomy? It is the excision of the gingiva. Okay, so what are the indications of gingivectomy? Yes, definitely gingival enlargement and also gingivoplasty. That is a condition like this. The second picture, you can do a reshaping of the gingiva, that is called as gingivoplasty, or you can do a gingivectomy. The second procedure in pocket elimination is your apically displaced flap, where you are going to displace the flap apically, as in case of surgical crown lengthening. Okay, you have a very short clinical crown. Patient is referred from the endo department. After root canal, I want to increase the crown height. I can't place the cap. So what you do a crown length. You assess the patient. If the probing pocket depth is normal, you plan for a surgical crown lengthening. Then you do a surgical bag, open a full thickness periodarshan flap. You reduce the bone around the tooth and you apically displace the flap. This is called as apically displaced flap. This is also a pocket elimination procedure. Next, what you have to highlight is on your pocket reduction procedures, the flap techniques what you use. Commonly what we are using is Kirkland flap, but you have to write a little bit on the classification where based on the papilla, management of the papilla is divided into conventional flap and papilla preservation flap. This conventional flap, we first talk about papilla preservation flap. See, when there is a wide interdental space, temperature is present, you don't go in for a normal Kirkland flap, you go in for a papilla preservation flap. Suppose I have a patient who is working in a social media, like she's a news leader in TV. So she doesn't want the sutures to be seen. So she will say, can you do some aesthetic procedures? These days this aesthetic dentistry is taking over all fields of dentistry. Okay. So they will ask you, so what time you will plan for a papilla preservation flap? So in papilla preservation flap, what you do is, you give a incision on the palatal aspect. Okay, so just below the interdental papilla, cellular incision is given, and you elevate the palatal papilla, push it through the interdental embouchure spaces buccally. So you are going to raise the buccal flap, curate the area completely, do any grafting procedure if it is required, and suture it back. So your sutures will be placed on the palatal aspect. So that is the advantage of papilla preservation flap. So you have to modify or choose the flap surgery based upon the condition. So just like how you are going to look into dental caries, you start looking into a periodontal conditions from today. So you will prosper better as a general dentist, because the second most common dental disease is your periodontal disease. Okay. Next one is your conventional flap. I think all of you would have seen this procedure in your dental clinics. where they are going to give a circular incision. Intrasulcular incision is given. A full thickness mucoperiosteal flap is elevated, and then you are going to do the scaling and root planing. You remove the infected granulation tissue, you do a regenerative or resective surgery and suture the area. This is the conventional flap. Next is your modified Whitman flap. So looking at the first picture, so if there is quite a bulk of interdental tissue or interdental papilla is very bulky, the margin gingiva is very bulky, you are going for a modified Whitman flap where you place an incision of 0.5 to 1 mm from the gingival margin. Then you place a sulcular incision or clavicular incision followed by an interdental incision. So you remove the bulk of tissue. So the bulk of tissue has been removed, the second picture, and a full thickness mucoperiosteal flap has been elevated, and the scaling and root planing has been done. And finally they have closed the sutures. So you are going to eliminate the pocket lining here. So now we are moving on to patterns of bone loss. You are bored or tired? You want a break? Yes? No? There is no white sleep. Okay. So these are the questions that is asked in your patterns of bone loss in your Tamil Nadu Indian University. And the most commonly asked question is enumerate the periodontal osseous defects. And all the other fall into that same question only. It is repeated in a number of years. So let us see how bone destruction takes place. As I already told you, inflammation is the primary cause for pocket formation. Inflammation is the primary cause for bone destruction. So we are dealing with inflammatory disease. As periodontitis itself is an inflammatory disease. So what happens? Any gingival inflammation can spread into the marrow space. Once it spreads into the marrow space, the space is filled with an edematous fluid, leukocytes and proliferating fibroblasts. So then what happens? There is increased number of osteoclasts and mononuclear cells. This will destroy the bone that is present there. There is thinning of the trabeculae. The quality of the bone is compromised, and that is how bone loss is taking place. I told you while discussing periodontal pocket, in intra-bony pocket there is an angular bone loss, where the bottom of the pocket is apical to the crest of the alveolar bone. The destruction takes place in this pattern only. So you are supposed to write this pattern of bone destruction. And there is destruction of bone, reduction in the bone height, and the fatty marrow is replaced by the fibrous marrow. So how does the inflammation spreads? Facially and lingually, the inflammation spreads from the gingiva to the outer periosteum, gingiva to the outer periosteum into the bone, or directly from the gingiva into the periodontal ligament. Interproximally, it spreads from the gingiva to the bone, or gingiva to the periodontal ligament and then to the bone, or gingiva to the bone and periodontal ligament. So this is how it is going to spread. So the bone destruction is caused by trauma from occlusion. This is quite a controversial topic, but as an undergraduate you can attempt to write this. Yes, trauma from occlusion causes angular bone loss. Next is systemic disease, but this concept is no longer followed. They say systemic disease causes bone loss. It is called as bone factor concept, but this has been disproved right now. Just as a part of the answer, we have to write it. What is radius of action? I think most of you know what is radius of action. Anyone? Yes. Tagore or any other college students, please give an answer. One of you. What is radius of action? This is just a rapid revision, right? This is what we are saying is what has to be written for the university examination. When you have a plaque formation, the bone loss takes place at a distance of 1.5 to 2.5 millimeters. So that is called as radius of action. Beyond the 2.5 millimeters, it has no effect on the bone. That is called as radius of action. So these are the factors that is going to determine the bone morphology. So how the bone defects are formed? It can be because of trauma from occlusion or aggressive periodontitis or some kind of a peripheral buttressing bone formation like lipping. So what pattern of destruction you see in aggressive periodontitis? Anyone can you tell me? In aggressive periodontitis, looking at the radiograph, what is the pattern of bone destruction that you see? With that you can say it is aggressive periodontitis. It's a very simple Anyone? Okay, read up. So this is the bone destruction pattern which we usually have. It can be a horizontal bone loss, where you can see a bone loss that is perpendicular to the long axis of the tooth. And you see that yellow line which is perpendicular to the long axis of the tooth, and it can be an angular bone loss. So this angular bone loss is again subclassified into 1-wall, 2-wall and 3-wall defect. This also they will ask in the examination. So 3-wall defect means what?
3-wall
Present or absent? Present. 2-wall?
2-wall
Intact. 1-wall?
1-wall
Very good. So for 1-wall, what is the treatment plan? Resective, or I'm giving you the answer. Choose. For 2-wall and 3-wall? Regenerative. Good. So what is this? Osseous crater. What do you understand by osseous crater? It is a concavity that is formed between the buccal wall and the lingual wall. This concavity is because of the food accumulation in the interproximal area. Why ma'am it is only affecting the interproximal area? Why it is not affecting the facial lingual wall? I am asking you as a student. Interproximal area is a source of blood supply. So the bacteria will first enter the interdental bone because it receives the blood supply there, it survives there, and in the same pattern how pocket formation takes place and how bone loss I will explain to you, it will cause destruction of the bone. So that is why there is a crater formation. Crater resembles potholes on the road. See, these days following rains, a lot of potholes on the road. So it is resembling a pothole in between the facial and lingual wall, which is a very ideal site for grafting. Okay, and the current concept is you do a bone grafting and also placing that is called as composite grafting. Okay, so that has got a better success rather than placing only bone graft alone. Okay, so this craters, if you see, they are more common on the posterior teeth and it forms 2/3 of the mandibular defects. Okay, 2/3 of the mandibular defects are osseous craters. Next type is, I think all of you know this, exostosis or torrent, which is a bulbous bone contour. It is an adaptation to excessive occlusal force. Next is reversed architecture. You tell me what is reversed architecture? Yes. There is a, usually the interdental bone is placed more coronally when compared to the facial and lingual bone. But in reversed architecture, the interdental bone is placed more equipotently when compared to the facial and lingual bone. Next one is your ledges. You can see how the ledges look like. You have a resective as well as if you have a defect here, you can do a regenerative membrane basement. What is buttressing bone formation? So the bone is going to adapt to the excessive occlusal forces by forming a new bone. If the bone is formed from the central portion of the jaw or maxilla or mandible to the periphery, it is called as central buttressing bone formation. It is formed from the periphery. Okay, it is called as peripheral buttressing bone formation. This I think you all know. Furcation. What is furcation involvement? Define furcation. Involvement of bifurcation or trifurcation of mandibular teeth with periodontal disease is called as furcation involvement. This is definitely sure short question in your Viva. All the candidates will be asked this question. Very commonly asked question. Classification of furcation involvement. According to Glickman, as an undergraduate, one classification is enough, one definition is enough. According to Glickman, what is grade 1? Good. Grade 2? What is cul-de-sac? It's an English word or? Yes? What word? Is it an English word? Then Greek word? Latin? Any other word? It's a French word. See, these days they have French windows. It's a new design in architecture, right? Many people want, no one wants windows like this. They want a French window. So what is that? Huh? One end of the window is shut and then is the other end is open. So it is a contained defect where you can pack the area with the bone graft. This is called as cul-de-sac. Okay, what is grade 3? 2 and 2. So what is the treatment plan? Make the area self-cleansing. Okay, grade 4? 2 and 2. What is the difference between grade 3 and grade 4? Recession. So what you will do in grade 4 for patient? Extraction and placement of dental implants. That is the correct focus. Okay. So this ends my lecture. And any questions? So I hope I have given you a brief idea of what has to be written in a university examination, and all the best for your examination. I hope all of you come out in flying colors, and I once again thank the management of your integration principal and Dr. Bhuvneshwari for giving me a chance to speak in this prestigious forum. Thank you. I would like to answer. You have any doubt? And one more point which I wanted to tell you is the pattern of answering the examination. You have to write the contents. Your synopsis is very important. If it is TNMJ University, it is going to be computer correction. I don't know about the lead universities. So your synopsis, you have to write the contents and elaborate on the contents. If it is going to be 10 marks, you write it in detail. If it is going to be 5 marks, the contents has to be the same. Okay? All the best.
Any doubts from the audience? That side, any doubts? Thank you, ma'am. I request Dr. Vaishnavi ma'am to felicitate our guest speaker with a certificate and memento. Thank you so much, ma'am. Thank you for your time. Shall we move on to the next lecture? Yes. The next lecture is next lecture is on periomedicine, which is once again a very elaborate topic and a very important topic. There are a lot of subtopics which you should know as final year students, right? And it is a very commonly missed topic. You fail to read it before you come for the exams because it is entirely theoretical. But you should also know that it is very important for your clinical practice, for you to know the implications, the periodontal implications of systemic disease and vice versa. So we have Dr. Divakar sir with us today. He is a professor in Karpaga Vinayakar Institute of Dental Sciences. He is going to be briefing us on the topic periomedicine. Sir, the stage is yours.
Good morning to all. So myself and Dr. Divakar. Thank you for having me here. So this is the first time I am doing something related to academics on stage. So I am glad that it is here in Tagore Dental College. So periodontal medicine, again, as Doctor said, it's a very important topic. The previous two topics which previous speakers handled. So they are little bit understandable topics. You will at least understand what's going on. Periodontal medicine, even if you try to understand, you will never understand what periodontal medicine is. Okay, so this will strictly be related to your exams. If periodontal medicine comes as an essay in your university exam, what you are supposed to write. That is all I am going to talk about for the next 30 minutes or 45 minutes. Okay? So before going, so these three people are like my backbone. So first is Dr. Saravana Kumar. This is just like a Thanksgiving since this is the first time. So he has been knowing me for the past 20 years. So 2004 August 1 I joined UG in Meenakshi Dental College. He was the first person I met. Yesterday he was the first person I messaged saying that I am going to Tagore related to some, I'm doing something related to academics this time. So he said, okay, thank you. Next is Dr. Ramakrishnan. He was my guide in PG. Dr. Ramakrishnan is a very senior person. He is actually Dr. Saravana Kumar's guide. Okay, so like he has seen many generations of periodontists. He was also surprised that I am coming here to do something related to academics. Last is my HOD, Dr. Anish. He is the HOD in Karpaga Vinayakar Institute of Dental Sciences. So he was the one who gave me this opportunity. He came like 2 years back, I think he came here. So this is just, if I am standing here and talking something related to perio in front of a crowd, these three people are the main leaders. Okay? So what is periodontal medicine? Do any of you know what is periodontal medicine? Or at least the brochure did you even bother to see what periodontal medicine is? What is it related to? Any idea? What? Systemic diseases. Very good. Okay, so that is the basic thing where something can go wrong. So periodontal medicine is something related to systemic diseases. That is the first bit of knowledge what you are supposed to have. In case if you don't know what periodontal medicine is, you go to the exam, you suddenly see this question and you don't know what it is, this is how the human brain will work. Okay, medicine, because strictly speaking, some 15 years back I had no idea what periodontal medicine is. If I had seen this question in my question paper, I would have thought this medicine was the kandipa matra and then I would have written something about antibiotics. Then konja padisirka something related to non-surgical therapy அப்படின்ற மாதிரி you would have written. அதுவும் இல்லை அப்படின்னா மெடிசன் பெரிடான்டல் மெடிசன் பெரியோ அப்படின்ற ரிவர்ஸ் சரி ஏதோ பாக்கெட்ல இருக்க விஷயம் போல you would have written about mouth washes. Okay, and in case if you are a very studious person, most modulation therapy because these are the common answers what UGs usually give. They don't know what periodontal medicine is. This is the answers what they usually give. None of them are correct. Okay, so all of them are wrong. As somebody said, periodontal medicine is related, something related to systemic disease. The connection between the oral cavity or your periodontium to the systemic diseases of the body. Okay, so if we have to talk in detail about periodontal medicine, we can conduct a 3-day program in periodontal medicine alone. Because so much of content is there. There are many systemic diseases which are related to the periodontium and vice versa. Periodontal disease will impact the systemic disease or the systemic disease will impact the periodontal status of the patient. Okay, so if we have to cover everything, we will need at least 2 to 3 days program. We have so much of content. Okay, so as an undergraduate student or as an exam going student, if this is an essay, what you are supposed to do. Okay, the common mistake what UGs do is they will be highly motivated. I should know everything about everything. Okay, so you cannot know everything about everything. Okay, nobody can gather so much of knowledge in undergraduate level or for that matter in the postgraduate level. Our brain is not tuned for that. Okay, you have to know something about everything. Okay, so in case even if you, for example, if you pray in a temple or you ask some question to God, also you will not get any answer. Okay, but if you go to this person or whatever you tell, you will give an answer. You will not get out. Our theory is you give a solution. Whatever you say, he will tell something. Okay, so that has to be the aim. Something relevant you are supposed to know as an undergraduate. Okay. Again, the next mistake what students commonly do is they will know everything about something. Okay. So what will happen is, for example, there are some 10 important questions or important chapters. What you will have for an internal exam or class test or whatever. So you will study 9. What will happen is that one chapter which we did not study, correct and only. Okay, so this is another mistake what you are not supposed to do. Okay, you cannot know everything about everything and you should not know everything about just few things. Okay, so the best option is you are supposed to train yourself like a fortune teller. Or using a relevant that you are supposed to tell something. Okay? Okay. So what is the last movie somebody saw? What is the last good movie somebody saw? What? Okay, take this for all that. Okay, so a movie is roughly 2.5 to 3 hours long. Okay, 2.5 to 3 hours long. But if I ask somebody about the story of a movie, nobody will sit and tell me for 2.5 hours. What happens is number one, he's an army, he's in the army, he gets married, he goes somewhere, he dies also. Okay, that is the story of the movie. Whose hero is Karthikeyan, whose hero is Sai. Okay? So this, whatever I spoke, these 6 or 7 lines about the movie are called as key points. Okay? So any question you study in period or any subject in that matter, these key words are important. If you are in a PG, it will not be like UG where they will give you a topic, they will tell you talk about this topic for 2 minutes. Okay? So if you see a movie and somebody asks you the story, how you are reciting the story in 2 minutes, you are supposed to talk or gather information in a way that you talk for 2 minutes. Okay? So okay, so how you are supposed to aim? What should be your aim? You gather knowledge, that will not work out in the undergraduate level. Okay? So the first thing, you are supposed to know what the question is about. So that is what we have been talking. If there is periodical medicine, you will not get marks. Okay? So what is it related to? That is the first thing. Next thing is, as ma'am in the previous session told, synopsis. That is your episode of Tarak Mandramari. Okay? So the difference, what textbook are you studying in Periodarshan? Okay? So what is the difference between current and chanting reality? Don't tell me foreign and local. Points. Okay? So Karanza, if you study 2 pages, whatever is useful for a UG, there will be 2 lines. But if you take Shanti priority, those 2 lines will be there. Okay? For show to mail Karanza Rachikla, but what will help us is Shanti priority. Okay? So that synopsis, the division of your answer. Okay? So whatever point you are gathering, you are supposed to you are supposed to gather it in such a way, they are divided into certain subheadings. Okay? Next is prepare key points. Just like how you will have plot points for a movie, you are supposed to have important key points. That is what we are going to talk. Key points is whatever will fetch you marks. Okay? Lastly, no other forms of questions. Okay? A single topic can be, or a single question can be asked in multiple different ways. Okay? The format of the question will be different. The periodical medicine is a different way of asking the question. The correct way of asking the question is, what is the impact of periodontitis on systemic disease? Okay, that is how the question is supposed to be asked. If we do not know that periodontal medicine is the other name for the question, you will not be able to understand. So what is the target? Again, as I said, I am going to achieve knowledge. All that you can do, but what is the primary target is you are supposed to get this mark in your whatever subject you are reading. For short note apply, you are supposed to score 2 or 3 marks out of 5, or if it is an essay out of 15, I am going to mark that. So that is the primary target. So whatever points you are gathering, you are supposed to gather in such a way that you fulfill this main criteria. Okay? So what is my objective here today is, by the end of this session, already everybody knows what is periodontal medicine. I am going to teach you what you are supposed to write under each of these things. Frequently asked questions in the university exam. Okay, it's a very important topic, and in recent days they are asked this very frequently. And what and how you are supposed to approach if this comes as a essay or a short note. So it is a branch of periodontology. So periodontal medicine is a branch of periodontology which deals with the effect of periodontal disease on systemic health of an individual. This is very, very important because the reverse is also there. Some systemic diseases will impact the periodontal disease also. You are not supposed to write that. You are supposed to write how a periodontal disease affects the systemic health. So history, this is not history of periodontal medicine as such, this is the history of the questions that they have asked. Okay? So don't bother about the questions, just look at the years. Okay? If you see from 2018 itself, even in February they have asked, in August they have asked, in 2020, that is from the same question paper. February 2020 question paper itself, they have asked one essay and one short note. November 20 again they have asked, 2022 again, the October batch they have asked twice, and even in the last exam, August 2004 exam, they have again asked. There are 2 essay forms from this chapter, the remaining are short notes. So we will take one question. So this is the essay, define periodontal medicine, discuss the effects of periodontal disease on systemic health. Okay, so this is the worst form of question you can have, because you have to write the entire chapter. Already you are supposed to write the entire thing. Okay, so this whatever I have written is the synopsis. The information what you are gathering should be under these headings. First is the definition, what we saw on the previous slide. It denotes the effect of periodontitis on the systemic health. Okay, so next subheading will be relationship between periodontitis and systemic health. There is something called as focal infection theory. Microbiology, but it's the same thing. Then, what is periodontal medicine? What was focal infection theory? What was wrong with focal infection theory, and why this periodontal medicine concept came? I think that we are supposed to know. Then, you have a wide range of diseases which are being affected by the periodontal status. So, first is the cardiovascular system, atherosclerosis, CSD, coronary heart disease, myocardial infarction, stroke. Okay, so these are the things related to the cardiovascular system which will be affected because of periodontal conditions. Next, endocrine system, diabetes mellitus. Okay, that is the most common disease that affects the periodontium, and that is the most common systemic disease and periodontal disease affects also. It is a two-way relationship. Okay. Next is reproductive system, preterm low birth weight defects. Okay, so it's something related with pregnancy. Next is respiratory system. There is something called as chronic obstructive pulmonary disease (COPD). Okay. Next is pneumonia. Both of them are lung infections. Okay. And some other new diseases which current research is still being done to elicit what correlation is there. So in the others, condition, if you reach the advances, you can write. But before that, whatever is on the screen, the previous slide and in this slide, everything you are supposed to know. The key points from here. So at least atherosclerosis, what happens? Myocardial infarction, what happens? Stroke, what happens? All of these things, at least 2 to 3 points you are supposed to know. So first is what is focal infection theory? Okay, focal infection theory, if you see in your books, there will be a very big paragraph. But what I have given here is only three sentences. Okay, so this is what is supposed to register in your mind. This was given by a person called William Hunter in the 1900s. So, maybe 100 years back, he gave this, that they told mouth is the center of infection for the entire body. Okay, so this was a very old concept. Whatever is wrong with the body, immediately they will look at the oral cavity. Again, the concept. So whatever problem you are having, it was directly related to your oral cavity. Okay, it was followed for a very long time. For decades, this was followed. Okay, but later it was proved wrong. They decided how it was proved wrong. Extraction of teeth. When the teeth in question, for example, 100 days back, the treatment for caries was extraction. They did not restore. And even before that, they are no Roshan, they thought diagnosis by a demon. So they are instead of extracting, they are killing the person. Okay? So he came from that type of lineage. So here what happened was when he said the tooth infection is the cause for periodontal disease and he was extracting, even then the disease was not curable. Okay, somebody went to say, for example, why we extract. But even after extracting the particular tooth, this stomach pain did not go away. So that was what questioned this particular thing. So this theory was discontinued. Okay, and lack of scientific evidence. Okay, so scientific evidence is all the journals, researches, articles, whatever you are being published. So why they are being done is, if you are saying something as a doctor, paracetamol, everybody knows you are supposed to take paracetamol, but you cannot tell it on your own. You need to have some scientific evidence. At least millions of people are treated using paracetamol. They became cure of, they became free of headache. It is an accepted mode of treatment. So that is what scientific evidence means. So all of these things were lacking in the focal infection theory. So after that, in 1980s and 1990s, when this research, everything became more prominent, there was a rise of evidence-based practice. So more and more research was done. Evidence-based dentistry or evidence-based decision making or a treatment plan. For example, you have a recession, now you have a bone loss, you are going to do some treatment. You should have some scientific evidence backing what you are deciding. Okay? So all those were done, and still they found out some oral pathogens were responsible for the systemic disease by entering the bloodstream. Okay, so they found a way, still in the oral cavity, still in the gingival sulcus or pocket or wherever, but they did not act there. They found a way to enter the blood circulation. Because of that, they caused the systemic disease. Okay, so how they did this is by 3 pathways. There are 3 major pathways by which the oral pathogen it affects or enters the bloodstream. What is metastasis? What is it related to metastasis? Cancer. Okay, you have cancer in one place, but it will spread to some other place. The same thing is happening here. The pathogen is in the gingival sulcus, but the infection will happen somewhere else. Okay, so there are basically 3 concepts: infection, injury, and inflammation. Okay, so this oral pathogens it will happen in the gingival sulcus also. Infection, injury, inflammation, everything will happen in the gingival sulcus also. But here what it does is metastasis. It will have the same effect on some other organ of the body. Okay, so finally what they arrived at was the periodontal pocket or the gingival sulcus acted as a reservoir. That is okay, my dear. Take you know how the water tank is on top of the house, but the water goes to the entire house. Same way. Periodontal pocket is in the oral cavity, but it spreads to all the organs of the body. So moving on to the first disease. So if you are writing an essay, the focal infection case, you are supposed to write just few words, few sentences, why it was declared or why it was not followed that much, and then you are supposed to write about this periodontal medicine and the three major pathways. If I am correcting your answer paper and this is an essay, those are the words I will look for. Okay. So the first thing is coronary heart disease, atherosclerosis. And again, synopsis. If it is an essay, you could have know because you have to manage your time, but this alone can come as a short. Okay. So synopsis first is in short coronary heart disease is CHD. Okay. What is CHD? You are supposed to define what is CHD. It is reduced or blockage of blood supply to the heart. So this picture. So this picture over here is not an artery or a vessel, it is a cement drain pipe. Okay, so what is the difference between both? In the clean artery, so same thing happens in your blood vessels. It is supposed to be like this, but due to some reason it will become like this, restricting the flow of blood to a particular organ. In this case, heart. Okay, so reduction or a blockage in the blood supply to the heart. So that is the definition of coronary heart disease. Atherosclerosis is a buildup of fat cholesterol on the blood vessel walls. Okay, so this blockage, what is blocking? So if the vessel is thickened with the deposition of fat, this is called as atherosclerosis. Both are interrelated. Atherosclerosis patient will have a ischemic heart disease or coronary heart disease. So what is the effect of periodontal infection on this atherosclerosis? The first is the periodontal pathogens. Why there is a bacteria or periodontal bacteria, whatever is there, it will increase the blood viscosity. What is viscosity? Flow. Okay, this is just viscous. It flow easily. Oil is more viscous, it will not flow easily. Okay, so blood is supposed to have a particular amount of viscosity. If it is increasing, blood over. So that is the basic understanding. So that increase in blood viscosity is being done by a periodontal pathogen. It is entering the bloodstream and it is doing this. Second is thrombogenesis. Thrombus means it is a clot. In simple terms, it is a clot. So the bacteria in the periodontal infection site will increase the chances of a clot formation in the vessel. If you are in the clot form, or it will be transported to the other parts of the body. Heart attack, varicose veins, or even a cerebral stroke. Okay? And atherosclerosis, the periodontal pathogens by themselves will cause deposition of fat inside the blood vessel. So this is the effect of periodontal infection on coronary heart disease. Whether the patient is having coronary heart disease or no, if he is having that particular periodontal pathogen, all of these things will happen. So the patient is more prone to get the disease. So this is called as risk. The patient will get risk. This is what we are supposed to estimate. Coronary heart disease immediately you are supposed to see how his oral cavity is. That is why from general medicine or general surgery, before doing any surgery or any procedure, they are sending them to the first aid. That is the focus of infection. You are supposed to remove the focus of infection. So in that periodontal infection or discrete spastic cavities. Okay. So what are the factors responsible? We have these three words: lipopolysaccharides, pro-inflammatory cytokines, and acute phase proteins. Periodontal medicine level, we are supposed to write. Okay, because when we are correcting, we will look for all these words. And one tip or what I can give is, if the question is something related or to PG, for periodontal medicine is PG level question. They are supposed to write for 2 hours, 3 hours. Okay, so that type of question, if it is asked in a UG level, you give marks. Okay, so these are the words which any person who is correcting the paper will look for. In my case, they have written something, they will give marks. Okay, so these are the factors responsible or factors present in the plaque and calculus which causes this irreversibility. So these three things that are present in the plaque and calculus will increase the risk of coronary heart disease. So this is the pathway in which this infection takes place. First, there is periodontal pathogens, courtesy of your plaque and calculus. Okay. So what they will do is gram-negative bacteria. So gram-negative bacteria, non-bacteria, so those bacteria are responsible for production of your lipopolysaccharides. They do something called as endothelial damage. Okay, so endothelium is the lining of the blood vessel. So they go and damage the endothelial lining. Cytokine, again, pro-inflammatory cytokine. So these cytokines are basically defense in the body. It will do something good. But due to some reason, if there is increased production of these cytokines, they will attack our own body. Okay, suppose we are going for a gang fight. The fight will be equal. But if we so the exact same thing will happen in case of increased cytokine production. This is like a gang fight. Because of some reason there will be increased production, you will not know which is the bacterial cell and which is the body cell. It will cause cell damage. Okay? Because of that, adenoma formation, vessel wall thickening, or thromboembolic events. Okay, so thromboembolic events is a clot in the blood vessel being transported somewhere else. Okay? Lower vessel or block can this clot will go to the brain. Okay, so that is a thromboembolic event. Okay, so if it gets dislodged, this is the next thing. This is stroke. All of these things are interrelated. If that thromboembolus forms and dislodges and suddenly goes and blocks something in your brain, that condition is called as a cerebral stroke. Okay, so stroke is nothing but blood supply to the brain is stopped. You have seen stroke patients. Okay, if you go to any movie, so if you go to the theaters, they will first show. He will not be able to do anything. If you bedridden, somebody has to feed him. So we will do while we do occasionally something like that because central nervous are very on the brain and nervous area. So there are two types of stroke. One is non-hemorrhagic and hemorrhagic. In the recent days, a lot of people are dying in the gyms. The gym what is the reason? What is that thing what? All those stress over strain on when they are lifting, blood vessels in the brain is getting ruptured. That is a thing. So that is the form of hemorrhagic stroke or aneurysm. So that is the lesser form of stroke that is happening. Okay? The majority 90% of stroke is non-hemorrhagic where there is just a block and the blood supply is cut off. Okay? So this periodontal pathogen, whatever is there in the oral cavity, they are directly linked to the non-hemorrhagic type of stroke. Okay? Increased plaque and calculus, what you have in your oral cavity, can one day cause a cerebral stroke if you have the risk factor. That is the importance. Okay? So what are the pathogenic factors associated with CHD and multiple sclerosis? Whatever we saw, all those cytokines, lipopolysaccharides, it is the same thing. It's just an extension. Okay? And one more to remember here is thromboembolic events. So till your ischemic heart disease or a coronary artery disease, there is just thickening of your blood vessel. There is no clot formation. If the clot forms into an embolus and it is transported somewhere, you will have this. Okay? So this is the simple understanding. So next, moving on to the most important systemic disease, which you are supposed to know. Okay? Name some systemic disease that is related to the Periodarshan. Okay? So it is very, very important from your exam point of view as well. So synopsis first, you are supposed to write what is diabetes mellitus. Diabetes mellitus